Okay. Okay. Take note of the patient's color. Is your patient pale? Is your patient cyanotic or pinkish? Are there signs of anemia? Okay. Shape of the fingernails. Is there clubbing? The position of the trachea. Is there shifting? Normally, your trachea is at the midline. Abnormality may take in the form of shift of the trachea either to the left or to the right, depending on the pathology in the lungs. Evidence of respiratory distress. Just by looking at your patient, pagkita pala nimot nawong, the face of the patient will tell you whether your patient is in respiratory distress. Observe the rate, the rhythm, the depth, effort of breathing. Inspect the neck for supraclavicular retraction, the use of accessory muscles of respiration. These are also evidences of respiratory distress. Listen to patient's breathing. Normally, you cannot hear, no? Very slight noise when the patient breathes. But that is for normal individuals. You may not be able to hear the breath sounds. But in patients with abnormality, any pathology in the lungs may cause increase or decrease in the breath sounds. Okay. Observe the shape of the chest. Observe for abnormalities like kyphoscoliosis, funnel chest, and the rest. No, barrel chest also, that's common. Okay. So that is for inspection. Okay. Another assessment of tactile fremitus. So fremitus, these are palpable vibrations transmitted through bronchopulmonary system to the chest wall. You ask your patient to say tres tres and you put your hands on the chest or on the surface of the chest where you are going to examine. So put your hands, palms on the surface of the chest and ask your patient to say tres tres. This will produce vibrations which will be felt by your palpating hand. So decreased fremitus or absent fremitus can be due to the following. Either your patient is speaking softly, so you ask your patient to speak a little bit louder. Okay. Another is transmission of vibrations is impeded by an obstructed bronchus, either by a foreign body or secretions. In COPD, in emphysematous patients, for example, there is increased or decreased rather of your fremitus. Pleural effusion, fluid will hinder the transmission of vibrations. Fibrosis and pneumothorax, the presence of air in the pleural cavity, will also hinder the transmission of vibration. Increased fremitus, on the other hand, is found in pneumonic consolidation. When there is consolidation in the lungs, this will cause an increase in fremitus. And lastly, you identify, you describe, and then localize areas of increased or decreased fremitus. Okay. Fremitus typically increase in the interscapular areas and disappears below the diaphragm. Interscapular areas, this is explained by the presence of your large airways, your right and left main bronchus. Okay, so these are the locations in the anterior chest where you are going to place your hands, your palms on the surface. So you'll notice that there are numbers. So you put both hands there, 1, and then you go down 2, and then the sides lateral 3. Okay, class, are you still with me?
Yes, Doc.
Okay. Okay, posteriorly, these are the areas where you are going to put your hands during feeling for fremitus or during your palpatory procedure. So 1 up, going down, 2, 3, 4 on the sides or lateral. Okay, the next procedure, inspection, palpation, and percussion. Percussion is a procedure which sets the chest wall and underlying tissue into motion, producing audible sounds or palpable vibrations. So this determines whether underlying tissue is air-filled, fluid-filled, or if it is solid. So the different percussion notes that you will encounter are the following. It is flat, dull, resonant, hyper-resonant, and tympanic. We say it's flat when an example is when you percuss the thigh area, your thigh. If you percuss that, the percussion finding will be flat. A pathologic example is the presence of large pleural effusion. Next is dullness. Okay, when you percuss the liver area, it will be dull. Pathologic example is the presence of a lobar pneumonia. Okay, resonance. Resonance is the normal lung percussion finding. Okay, so you can find that in normal lungs, in bronchitic patients, asthmatic patients, they may present with resonance. Hyperresonance, on the other hand, will be found in emphysema, excuse me, and pneumothorax. Tympanitic or tympany is when you percuss the stomach area or for the gastric wall. Excuse me. Okay, so this diagram will show you where you are going to percuss. So you start up above your clavicle, because we said that the lung extends beyond your clavicle. So you have to also percuss these areas. So one from the right, okay, if you are facing your patient, you start from the right, going to the left, down, across, down, across, down, across, and then 5 and 6, the lateral sides of the chest. Okay, so you will notice that there is a systematic way in your examination. So more or less, the whole area is covered by your PE. So there is less tendency for you to miss abnormal findings. Okay. So the areas where you are going to percuss are also the areas where you are going to auscultate. So you put your diaphragm or your bell of your stethoscope on these areas. Okay, this anterior, is the posterior areas. So percussion and auscultation will be done on these areas. So take note of the number. Okay, 1, 2. Okay, never forget. Sometimes or oftentimes clinicians forget to auscultate or percuss the lateral sides, the sides of the chest. No. Oftentimes, hingangalimtan ito here. Okay. Identify again, describe, localize any area of abnormal percussion note. Abnormal percussion note, whether it is hyperresonant, it is dull, whether it is resonant. No, those are your percussion findings on the chest. Resonant, hyperresonant. Okay. Identify the level of diaphragmatic dullness. Okay. Then we go to auscultation with the use of your stethoscope. So by the way, during our clinics next time, next meeting or next week, you now bring your apparatus, no, your stethoscope, your your pen light, okay? Maski tulaan na hirap, pen light and stethoscope. Ay, your BP apparatus na yan. Your blood pressure apparatus, your stethoscope, and pen light. Okay? So we now go to auscultation. This is done to estimate the airflow and to detect obstruction. Assess the condition of surrounding lung, pleural space, and it involves listening to sounds generated by breathing. Listening to adventitious sounds. Adventitious sounds are additional sounds, no? Apart from your normal breathing sounds, you may hear crackles or wheeze, and these are called adventitious sounds. Listening to patients' spoken or whispered words, this is done with the use of your stethoscope. Okay. The different breath sounds that you may hear. Vesicular breath sounds. These are described as soft, low-pitched, heard through inspiration, heard over most lungs, with a longer inspiratory phase than expiratory phase. So the majority of your breath sounds when you auscultate the normal lung is vesicular breath sounds. Okay. Then we have the bronchovesicular breath sounds, where inspiratory phase is equal to the expiratory phase. Heard best in the first and second interspaces anteriorly and between the scapula. Then we have bronchial breath sounds, where expiratory phase is longer than inspiratory phase, heard at the manubrium sterni. And then you have tracheal sounds, where inspiration is equal to the expiration phase. This very loud and heard over the trachea. So then we have crackles. Crackles, or ang kadaan nito ang tawag rals. Rals or crackles. We have fine crackles described as soft, high-pitched, very brief. And we have coarse crackles, which are louder, lower-pitched, and not so brief. Then we have wheezes. This is a finding in your asthmatic patients, in your bronchitic patients, and sometimes also in patients who have congestive heart failure. They may present also with a wheeze. Wheezes are relatively high-pitched and have a hissing or shrill quality, while rhonchi are relatively low-pitched and have a snoring quality. Okay. So, transmitted voice sounds. These are sounds which are heard when there is consolidation of the lungs. When you ask your patient to say 99, normally the sounds are transmitted through the chest wall, are muffled and indistinct. When the sound is louder, clearer voice sounds are called bronchophony. When you ask the patient to say E, you will normally hear muffled long E sound. When the E is heard as A, it's called egophony. Ask the patient to whisper 99. When the whispered voice is normally heard faintly and indistinctly, louder, clearer whispered sounds are called whispered pectoriloquy. Okay. So, PE of the posterior chest. Again, you do your inspection. When you examine the anterior chest, you inspect, you palpate, you percuss, and you auscultate. When you examine the posterior chest, you also do the same. You start with inspection. From a midline position behind the patient, take note of the shape of the chest and the way in which it moves, including deformities or asymmetry. Okay. Abnormal retraction of the interspaces during inspiration, which may signify the presence of difficulty of breathing. Impairment in respiratory movement or unilateral lag, which may indicate the presence of massive pleural effusion or pneumothorax. Okay, deformities or asymmetry and mga kyphoscoliosis, no? Bulging of one hemithorax. You compare both sides. Normally they should be symmetrical. Okay. Again, you palpate to identify tender areas. Assessment to observe abnormalities such as masses or sinus tracts. Further assessment of respiratory expansion, and then assessment of tactile fremitus. Palpate and compare symmetrical areas of the lungs using either the ball of your hand or the ulnar surface of your hand. This is also done as a scouting maneuver because it directs your attention to possible abnormalities. Okay, the technique of percussion. By the way, this percussion, palpation, percussion, this will be done also not only in the examination of the lungs, but you will use this when you examine the heart, when you examine the abdomen. So at this point, dapat mag-start na ka mo pag-practice, no? Practice on your percussion, which is quite the more difficult process, no? Compared to your inspection, palpation, auscultation. The percussion, you need practice. The technique here is hyperextend the middle finger. If you are right-handed, no? If you are right-handed, hyperextend the middle finger of your left hand. You call this your pleximeter finger. Press its distal interphalangeal joint firmly on the surface to be percussed. Okay. Position your right forearm quite close to the surface with the hand cocked upward. With quick, sharp, but relaxed wrist motion, strike the pleximeter finger with the right middle finger, which we now call the plexor. Okay, you have your pleximeter finger, and then you have your plexor. Aim at your distal interphalangeal joint. Okay, na-imagine niyo? Ginaano? Naka-imagine ka mo? Hoy.
Yes po.
Yes, Doc.
Okay. Well, after you strike, pag-strike niyo, di ba, you strike the distal interphalangeal joint with your plexor. 2 strikes, and then you transfer to the other area. So 1, 2, transfer to the next area. It should be sharp, quick wrist motion. Diri kay bugos nga kamot nimo, bugos nga arm imo ibubunal dito, no? It should be quick wrist motion. 2 sharp strikes, and then you transfer to another area of percussion. Okay. Abnormal auscultatory finding or abnormal breath sounds. Okay, normally the respiratory rate is 14 to 20 per minute in adults and 44 per minute in infants. Okay. Rapid shallow breathing, you call that tachypnea. So from this point now, you use now your correct medical terms. For rapid shallow breathing, you call that tachypnea. This is due to restrictive lung disease, pleuritic chest pain, and elevated diaphragm. Rapid deep breathing, you call that hyperpnea or hyperventilation. Rapid deep, in contrast to your rapid shallow, tachypnea. Rapid deep, you call that hyperventilation. This may be due to exercise, anxiety, metabolic acidosis. And then you have the so-called Kussmaul's breathing, which is deep breathing associated with metabolic acidosis. It may be fast, normal, or slow. Your patients who are diabetic, which may show metabolic acidosis, the breathing there, which you may find is so-called Cosmos breathing. Slow breathing, on the other hand, is called bradypnea, okay, which may be due to diabetic coma, drug-induced respiratory depression, and increased intracranial pressure. So you may now use these terms: tachypnea, hyperventilation, bradypnea, Cosmos breathing. You would now practice using these terms. Okay. Okay. Then we have the so-called Cheyne-Stokes breathing, where respiration waxes and wanes in a cycle with periods of deep breathing, which alternate with periods of apnea, usually seen in patients with uremia and brain damage. Then we have ataxic breathing or Biot's breathing, characterized by unpredictable irregularity. Causes can be depression of brain damage at the medullary level. Okay, this chart will show you abnormalities in the thoracic cage. Normal adult, the thorax in the normal adult is wider than it is deep, meaning its lateral diameter is larger than its anterior-posterior diameter. In contrast to barrel chest naman, an imo anterior-posterior diameter is wider than your lateral. Okay. This is seen in where? COPD patients or emphysematous patients, and maybe in aged individual and in infants. Okay. Then you have the pectus excavatum or funnel chest. The clinical significance of this may compress the heart and great vessels, which may cause murmurs. Then we have the so-called pectus carinatum and then thoracic kyphoscoliosis. Thoracic kyphoscoliosis, the significance of this is these patients will go into cor pulmonale. They usually die of cor pulmonale in stage, no? Okay. This one here, this is important. This is found in your Bates. This graph will show you the abnormalities, comparison of the PE findings on auscultation, your palpation, percussion, on okay, inspection. Okay, normally, we say the percussion note is resonant, the trachea is midline, the breath sounds mostly vesicular. You may not hear adventitious sounds, so no rowels, no crackles, no wheeze. Okay, the tactile fremitus is unimpaired, meaning it is not increased or decreased, so normal, unimpaired. In consolidation, in contrast, in patients with consolidation, pneumonia, no? The percussion note is dull over that area. The trachea is not shifted. It is located at the midline. The breath sounds bronchial over the involved area. And you now find adventitious sounds. You hear crackles. And the tactile fremitus is increased on that involved area. So you have increased fremitus with additional findings of bronchophony, egophony, and whispered pectoriloquy. So that is a finding of your pneumonic consolidation. Okay, and atelectasis naman, the percussion finding is dull. The trachea now is shifted towards the pathologic side of the lung. So ginahatak hiya towards the pathologic side or the diseased side. Okay, usually absent breath sounds. Okay, fremitus is absent. Pwede gihapon ka mo makabatihin ano, pero usually no, you cannot hear crackles or wheeze. No? Pleural effusion, dull on percussion. The trachea now, in contrast to atelectasis, is shifted towards the normal. Ginpupus siya towards the normal side. Okay? Decreased to absent breath sounds, but bronchial breath sounds may be heard near the top of the large effusion. Okay. Ang imong fremitus naman is decreased to absent. Okay? Pneumothorax, hyperresonant on percussion, shifted towards the opposite side of the hemotrachea, decreased to absent breath sounds, and the fremitus is decreased to absent. So these are the PE, abnormal PE findings in this condition. Okay. So this is a normal chest X-ray. You'll notice that the trachea is at the midline, the heart is not enlarged, the intercostal spaces are not widened, you do not see any infiltrates, you do not see any consolidation or anything, no? The lungs are well expanded. The costophrenic angles are sharp, meaning there is no fluid there. Okay, this is a normal chest X-ray. Okay, this one naman is an X-ray showing a large pleural effusion. You will notice that the heart is shifted towards the normal side because it is pushed by the fluid. And you have the meniscus sign above the density. You see a whitish density, the density on the right, mid and lower lung fields with a meniscus sign above, no? So the lucent, the lucent or the dark areas there is the lungs. Below it is occupied by pleural fluid. Okay. This one here is an X-ray of a patient with pneumothorax. You will notice that the heart, there's a radiolucency rather on the right, the whole of the right. This is a large pneumothorax, no? Almost 90%. Oh, 90%. Okay. You can see the pleural line on the right side. Okay. The right side, you have the pleural line there. Makikita nimo right side ang pleural line, and the dark area here is your pneumothorax. This one here, you have an atelectatic upper lung. Okay, your trachea, makikita nimo, your trachea is shifted towards, nahatak towards the abnormal side. Di ba, area igbaw? Your trachea is shifted towards the right. Okay, while your X-ray, the X-ray on your right is also atelectasis, a large atelectasis on the right. How can you differentiate an atelectatic lung from the presence of, because you can see also density here, no? Pero pareho yan pleural fluid. But in atelectasis, you can see that the heart is not pushed towards the normal side. Nahahatak here towards the abnormal side. You cannot even see the heart. If that is in case of pleural fluid, you will see that the heart will be shifted towards the right. Mapupush here towards the normal side. And the trachea here, you can see the line of the trachea is shifted towards the abnormal side. Nahahatak here towards the abnormal side. Okay, this X-ray here is shows the presence of lung abscess here, no? Lung abscess on the right upper lung. Okay, where the arrows are pointed. That's a lung abscess. This one here is an X-ray showing pneumonic consolidation on the right base. Okay, that density, that whitish area there on the right lower lung field signifies the presence of a pneumonic consolidation, pneumonia. Okay. Okay. This X-ray shows emphysema, okay, in chronic obstructive pulmonary disease, emphysematous patient. You see that the heart is tubular in the midline, okay. The diaphragms are low, and the intercostal spaces are widened. And the ribs far apart. The intercostal space are widened. The heart is tubular in the midline. and the diaphragms are flattened. Bubo. Okay. So that's the end. Okay, do you have any question, class? Anything you want clarified? Hi.
None. So
Because if we have done our lecture face to face, I would have shown you how to examine the chest, no? But kung man ka mo, gusto man ka mo Zoom, oh, so dito makag-demonstration. Although the demo will be done by your preceptors in clinic. By the way, how do you write your PE findings? Okay, if you go into recording of your findings of the chest, you start with inspection. Inspection, palpation, percussion, and auscultation. Normally, not normal findings. What are the normal findings during inspection? Huna-huna ito niyo, ha? Normal findings during inspection, during palpation, percussion, and auscultation. So, inspection, normal. So, symmetrical expansion, no lagging, regular respiratory excursions with no signs of respiratory distress. No, intercostal, subcostal retraction. Okay? So, that's your normal inspection findings. Pag palpation naman, masin ka mo, no or normal or unimpaired tactile fremitus. Okay. Unimpaired tactile fremitus. Percussion findings, masin ka mo nga, what? Resonant. Di ba normal? Resonant percussion findings, resonant on percussion, and then auscultation, masaring ka mo nga, vesicular breath sounds, no crackles, no wheeze. So that's more or less a normal finding. Okay? Hoy. Bati ka
yes,
mo.
Doc.
Yes, Doc.
Pag pleural effusion naman, siguro masaring ka mo inspection. If it's massive pleural effusion, there will be asymmetrical chest expansion, lagging on the right side. For example, if your pleural effusion is on the right, lagging on the right side with subcostal, intercostal retractions. So dito. And massive nga ni siguro ikukuha niyo yung trachea. So it's impossible for you to look at the trachea, no? Determine niyo. And then pag palpation naman, you'll say that decreased tactile fremitus. Okay, decreased tactile fremitus. Percussion naman, masing ka mga dull on percussion or flat on percussion on the area where there is pleural effusion. Auscultation naman, masing ka mga decreased to absent breath sounds on the right, mid to lower lung fields. Okay. By the way, you do not say the upper lobe, lower lobe, no. You divide the lungs into three, the upper or apex, upper lung field, mid lung field, and lower lung field in order for you to localize your finding. Masin ka mo, dullness on percussion on the left lower lung field, or decreased fremitus on the left lower lung field, or decreased breath sounds on the apex or upper lung field, or decreased breath sounds from the mid to lower lung field on the right. That's how you localize your findings. You do not say upper lobe because di kat marang kung upper lobe ito yung kukat. You just divide the lungs into upper lung field, middle lung field, and lower lung field. Or you can say apex, mid, and then basal lung fields. On the base, apex and base. Okay?
Yes, Doc.
Yes, Doc.
Anyway, you'll be taught by your preceptors. Tutundaan mo kami yung preceptors ito. So, no questions about the practical exam here. Dr. Limos is already here. The group of Dr. Limos, you proceed to EVMC. How about the group of Dr. Di Coco?
Nag-mention si Doc Rico ko last week, Doc, nasa RTR lang din daw po yung group niya.
Okay. So, pwede naman ngayon kita, we can go to the school. Wala man kung examine niya, net bar. So, my group, you can go to, ha? Sorry?
Later po,
Dili
one
pwede
o'clock
sa
po.
main building.
For clinics ba later, Chels?
For clinics, can we go to school na? Are we allowed to go there na? Wala naman daw ko ng barya na. Next week pa man.
Pero sa med building, Doc, is not
Okay, we'll just look for a vacant room there, anywhere in the school. Can we?
We'll chat, Ma'am Abby po.
Nagtawag ako kanabi, okay naman daw kuno, you can go, pwede man kuno dito. Anyway, we'll just look for a vacant room anywhere there this afternoon, 1 p.m. for my group.
Okay po, Doc.
Okay, sige. So, see you there, 1 p.m. Okay, good morning.
Thank you, Doc.
Thank you, Doc.
Thank you,
Thank you,
Doc.
Doc.